can help us in identify. It can identify the cause of entrapment. Example, a scar of a prior surgery. MR neurography and MRI LS spine should be done to rule out anywhere is there any compression because any lesion in the course of the nerve. So these two papers I had undergone after the right inguinal nerve block was given and that further diagnosis was being made on the basis of paravertebral block. She refused any surgical therapy, ablation, radio frequency, whatever was to her. And so, botulinum toxin subcutaneous injection femoral nerve, which is which the patient accepted despite the off-label nature of the treatment. So, this procedure involved using 100-unit vials of Botox, and it was diluted in a dilution of 50 units per ml with NS. In the first round of injections, they gave around 75 units. In the second round, 100 units, and in the third, 150 units. So they gave subcutaneous injection using 27 gauge needles, 12.5 mm needles, and they used lignocaine 5% topical application to make the patient comfortable. And they pinched the nerve around the skin just to separate the layer from cutaneous to muscular for a proper treatment. This is the 75, the first, when they give the first time injection territory of the genitofemoral nerve. So this is what they did for the first treat. So this is 75 units, 100 units, and 130 units, 150 units given as first line, second line, and third time injection. Score was, and T1 means at the time of presentation of 1 month and 1 week, what the patient presented, what the pain score was. So you can see the NRS score improved from 9 to 4 after the first treatment and stayed for about it decreased from 8 to 3 and it stayed for about 3 months. And when they used third time 150 units, from 8 it came down to 1, which was very significant. It stayed for around 4 months. So what are the treatment options available for genitofemoral neuralgia? Patient can opt for conservative treatment. So we can start with the first line like gabapentin, pregabalin, TCAs, SNRIs, and lidocaine patches. Then SSRIs, MD, intervention, opioids, capsaicin will come later on. Then other non-surgical approaches which are minimally invasive have to be tried after that. They should be offered. So select a serial nerve blocks should be offered to the patients. If serial nerve blocks are effective, it is fine. If they are very short lived, you can go ask the patient to go ahead with the radio frequency ablation or cryoablation, or even people have tried DRG stimulation, PNS implantations, spinal cord fracture cases. Also very important, all these genitofemoral neuralgia patients are very much affected mentally. I mean, they are very much disturbed. They go in depression. They are very anxious. So right time psychologist should be brought into picture and counseling should be done. In this paper, they have given a proper flow chart for intractable and refractory genitofemoral and ilioinguinal neuralgias. So they have asked to start with medical treatment, then to go ahead with the nerve blocks, cryotherapy, or radio frequency ablations. And as a last resort can be, if nothing works, they can go ahead and place the user first locate the femoral artery and trace longitudinally, and you see the external iliac artery. It starts dipping at that level. You can see, and you change the probe again to the transverse level. You can see the spermatic cord with its contents, and there can be testicular artery there. So we have to be really vigilant, and we have to have negative aspiration and be careful when injecting the drug. So you can see the femoral artery, and it is dipping when we go cephalate. It is dipping to the external iliac artery, and you can see the spermatic cord and its contents. All other option can be at the level of the pubic buccal, and there also you can locate the spermatic cord and its contents. Will be the sperm. In case of female, there will be males, there will be spermatic cord, and there will be artery to the vas deferens. You will be having two nerves, mainly two nerves are genital branch of genitofemoral, inguinal nerve. Want to block femoral branch of the genitofemoral nerve, you have to place your transducer transversely, locate the your femoral vein, femoral artery, and femoral nerve just near the femoral nerve, and a little medially over the femoral artery, you'll be able to look. So further, if the patient denies all these treatment, what treatment do we have? So we have to patient. We can ask the patient to go ahead with the surgical treatment. So genitofemoral neurectomy or triple neurectomy of all these three nerves, that is ilioinguinal, iliohypogastric, could lead to complete pain relief. And the inevitable complications of neurectomy are the anesthesia over the skin innervated by the genitofemoral nerve and other nerves when triple neurectomy is performed. So, and as well as there'll be loss of the cremasteric reflex. So why have these patients used Botox? Because patient refused all the treatment options, and the first two treatments were able to significantly reduce almost complete pain remission, but the period was only for 4 months. So the duration and efficacy could be dose related. With higher doses and the duration and efficacy seems to increase, and the treatment also has already been proven to be effective in trigeminal neuralgia, post-herpetic neuralgia, diabetic neuropathy with level A evidence, and it usually works for a period of around 3 months. It has also been found to be beneficial in occipital neuralgia, CRPS syndrome, chronic pelvic pain syndrome, type of episodic auriculotemporal neuralgias, and post-herpetic neuralgia. So mechanism, we all know that it interferes with the expression of TRP1 receptors, inhibits the release of CGRP and substance P, and it enhances the inhibitory effect of opioids and GABA activation. So conclude, botulinum could be safe and effective therapy for refractory cases of genitofemoral neuralgia. However, larger studies with a placebo-controlled design are need to confirm its efficacy and the appropriate doses. So, ma'am, should I go ahead with the second also?
Yes. I just want to say that
Hello?
for everyone's info, we have the paper I shared. The extra information was added by Dr. Anamika just for everyone to be aware of. There are other options. We have to think about other differentials and just the better clarity of the anatomy. So you can proceed with the second one, Dr. Anamika.
Okay, ma'am.
You can just go to your screen again, the PowerPoint. Yes.
Again, ma'am, it's on. Yes.
It's visible. It's visible,
Okay.
Anamika.
Okay.
It's visible.
So
yes.
Coming on to the second case report, it's about the post-transplantation triple neuralgia. Again, a case report. So this patient was 74-year-old woman. She came to pain clinic with right lower abdominal pain, and it started 4 hours prior to the presentation in clinic, immediately after the renal trial, which started was at the incision scar, and it radiated to the suprapubic right groin area and was constant, sharp, and burning in nature. The patient also reported anterolateral thigh pain, which was stopping at the level of above the knee. So on initial inspection, the patient appeared obese, had well-healed right abdominal scar. So in further history, the patient had already taken some physical therapy, acupuncture, steroid injection at the surgical site. None of these treatments helped her. So 3 years after the onset, means 1 year before the patient presented, the patient underwent right ilioinguinal nerve resection. Now, this was also insufficient in managing the patient's symptoms, and she reported taking 5 milligrams of oxycodone daily at night to help her with sleep. Means it was affecting her daily living as well. So this was the patient picture taken from the main case report, and you can see the surgical scar. It's healed well. Now, what happens is in patients with renal transplant, the incidence of, in general, also incidence of neuropathy seems to be higher in patients who are diabetic or hypertensive and those with graft rejection episodes. Now, the causes can be either CNS infection due to immunosuppression, or they can be the use of medications that are used for the immunosuppression in these patients. They are the potential candidates for peripheral neuropathy, or because of the disease following the skin cancer. The most common malignancy in post-transplant patients is post-transplant lymphoproliferative disorder. Because of these, they typically they occur in the lymph nodes, and they have localized symptoms of compression, and they may lead to compression symptoms of the nerve, producing neuralgia later. So neuropathy can also develop as a result of technique used during the surgery, because of the retractors during the surgery or cut during the surgery. Now, further, how did they make the diagnosis? So, a diagnostic ultrasound guided right inguinal block was given, and but there was residual, there was 50% abdominal pain relief to the patient, but there was residual pubic as well as thigh pain. So, further, ultrasound guided right genitofemoral nerve block, and the patient, this provided more than 50% relief in the suprapubic and groin area, but did not alleviate the pain in the anterolateral thigh pain. So a right lateral femoral cutaneous nerve block was performed to address anterolateral thigh pain, and this was ilioinguinal, genitofemoral, and LFCN neuralgia, that is lateral femoral cutaneous nerve neuralgia, was made. So for the treatment on the next visit, both the pain of the lower abdomen as well as the upper pubic and groin area were okay. Only the patient was affected by the right anterolateral thigh pain. So they again, for that, the patient was suggested to go ahead with the right LFCN radiofrequency ablation, which was performed at 80 degrees Celsius over 2 minutes. And 2 days following the procedure, the patient experienced soreness and burning sensation in that area. So that was post radiofrequency neuritis. To curb that, they had given another right LFCN block, and this provided immediate pain relief lasting for 24 hours. So this is the picture again I've put just to show that the ilioinguinal hypogastric, just lateral part of the psoas muscle, when they come out the muscles, two muscle layers, basically the internal oblique and the transverse abdominis. And then if we put the ultrasound, the ilioinguinal is more closer to your ASIS, and hypogastric is little away, but they're closer together. And then they further go on. Ilioinguinal, iliohypogastric gives a further lateral branch to the hip area, outer part of the hip area. Just little area is being covered that you can see in the blue demarcation, and the lower abdominal area. And ilioinguinal, we have already discussed this. So neuralgia paresthetica, that is because of the lateral femoral cutaneous nerve that again further turns and goes behind, just below the inguinal ligament, and supplies the anterolateral part of the thigh. And if you see in the right side of the screen, you can see the lateral femoral cutaneous nerve is just above the sartorius muscle, and just below the fascia lata, and between the fascia lata and fascia iliaca. And then you can see further when you look at the femoral artery, femoral nerve, and femoral vein, their arrangement. You can see just near the femoral nerve, just above that, and next to the femoral artery, you can see the genitofemoral nerve. So when you scan for the ilioinguinal nerve block, we know we have to trace the direction from ASIS to umbilicus area. In this line, when we go and little tracing, we can see that between between internal oblique and the transverse abdominis, you can see the ilioinguinal and iliohypogastric. Ilioinguinal is more closer to the ASIS. And here an artery, deep circumflex iliac artery is there, so you need to be little vigilant when injecting drug. Further, for LCFN, when you trace in the transducer, keep the transducer in the horizontal position, medial to lateral. When you come from medial direction to laterally, you can see the sartorius muscle, and just above that, you can see a pocket. That is the LCFN. So all these are the pictures showing the SAM means sartorius muscle. Above that, you can see LFCN, and below that is the your tensor fascial lata muscle. So further on in this case report, what happened is follow-up was done at 14 days after the right LFCN block, and the patient agreed for a PNS trial targeting the right LFCN. Now this provided more than 80% immediate relief, Due to the efficacy of the temporary treatment, the patient agreed to go ahead with the permanent peripheral nerve stimulator. Now, what is the criteria for patient selection? So first is patient should be consistent with the sensory distribution of a single peripheral nerve. In our case, it is the lateral femoral cutaneous nerve. A positive diagnostic peripheral nerve block should be there. Exclusion of nerve entrapment neuropathies, and the patient is free of major psychological or psychiatric diseases. So for the procedure, the patient was placed in supine position and the area was prepared in sterile manner. We are using 15 number blade scalpel. A stim router was put. It is a PNS implant. It was done. And after confirmation of the sensory stimulus in the area of targeted nerve under direct ultrasound visualization, an external pulse generator was then programmed to the level of stimulation that provided the most pain relief. And she reported significant decreased pain in the days leading up to second month follow-up on phone call and did not feel the need to use the stimulator during this period. So this is how it is implanted. We put an at least a 14 gauge needle is being used to put the implant lead inside near the nerve which is being affected, and then it is further on connected to the external pulse transmitter and the patient programmer. So just I didn't get a picture for LFCN, so I got this picture from Google for they have used the stimulator for the femoral nerve. And they've placed one horizontal lead and one longitudinal lead below the inguinal ligament using ultrasound. And above you can see the programmer. So this is the these are the leads which are being put. You can see the needle tip and the lead introducer, and then you can through that you can put a lead just next to the femoral nerve, and then you stimulate and check whether for your targeted stimulation. So this is what they have used. Stim router with its diameter is 1.2 mm, 15 centimeter length. Electrodes 3 are used in this case, and we have frequency, we have intensity, and pulse width. These are the variables which are available that we have to set as per the patient. So how does it work? So the PNS is based on gate control theory, and according to it, large diameter non-nociceptive sensory fibers, A beta nerve fibers, carry signals to interneurons located in dorsal horn of the spinal cord, and these signals are thought to inhibit the transmission of nociceptive signals from smaller diameter C fibers, effectively closing the pain gate. Now, PNS may also alter the release of endogenous neurotransmitters. Now, further, it also affects the plasticity of the NMDA pathways, which are known to be involved in pain. So, there has been a case control study involving 94 patients. They concluded that over 60% of the patients who underwent PNS device placement experienced long-term pain relief. So, the reference has been given in bracket. So for the genitofemoral peripheral nerve stimulator implantation for the refractory groin pain, this was also a case report. The patient experienced over 90% pain relief after 1 week. At 1 and 5 months post implantation follow-up, the average pain score was were 1 and 0.5. So the PNS implantation may be promising intervention when other analgesic modalities have failed to manage the refractory GFN. Other that I've seen is PNS, peripheral nerve stimulation and clinical outcomes, a retrospective study, as well as the PNS stimulation for pain management and review. In all these papers, they have shown that it has been shown to reduce at least 50% difference was there in the pain score. It was significant to say yes, it works in refractory cases. Further, neuralgia, trigeminal neuralgia with good pain relief. So to conclude, neuropathic pain following renal transplantation is a much more common issue than previously thought and should be overlooked by managing physicians. And commonly affected nerves are ilioinguinal, iliohypogastric, genitofemoral, and lateral femoral. Managing pain includes nerve blocks, RFA, PNS if conservative therapy fails or is inadequate. Thank you.
Great job, Dr. Anamika.
Any questions?
That's a very well, actually you covered both the topics really well, and I appreciate the extra slides and effort you have put in to show us the anatomy as well as how these peripheral nerves implants can be placed, can be helpful in other nerves as well. Dr. Raj sir, do you have any experience of like when can we like peripheral nerve stimulators will be available in India so we can?
We don't have peripheral nerve stimulators in India.
Yeah, we don't have it in India yet, but it's much complicated.
Looks simpler.
I mean, when I was doing my fellowship in US, then we have used the peripheral nerve stimulators. It's much easier than the central ones.
Yeah, and the one from Nalu. We are shown this slide. They are the peripheral stimulators from the Nalu. It is kind of a Wi-Fi device. So you can put it even in the epidural space for failed back syndrome, and it connects via Wi-Fi. You don't have to put an IPG inside.
Okay.
So our controller is in your pocket. You can control it from externally. So it's a stimulator which works on a Wi-Fi mode. You can control it from outside.
Dr. Sai is asking any idea about StimPod, the non-invasive one.
And these RFs, RF, PRF, I don't know. I don't think the radio frequency.
We don't have it yet. Probably when Boston will come and in one of our ISSP cons, then probably we can have.
Boston is only at the minute is into this thing.
See, it shows it has started screen.
Yes, ma'am.
Sharing,
Can
but
see.
yeah, we can see it now. You can make it full
Can you see
screen.
now?
Yeah, you can make it full screen. And bring it to your first slide.
Yeah, I have done that. Yeah, I have done that. Can you see my first slide?
Yes.
Yes, ma'am. Yes.
Yeah. Okay. Good evening, everyone. After such an exhausting discussion by Anamika, mine is a very small presentation. I'll be discussing about that this very small. This is a topic: superior hypogastric plexus block as an effective treatment method for endometriosis-related chronic pelvic pain. It's a open pilot clinical trial, and it is published in the Journal of Obstetrics and Gynecology in the year of 2021. Now, before discussing this topic, what is already known about the subject? We all know that the safety and efficacy of superior hypogastric plexus block treatment, safety and efficacy of this block is there in the treatment of the chronic pelvic pain, and it has been revealed in our earlier studies. But the efficacy of superior hypogastric plexus block for the pain management in patients with the refractory endometriosis, this has not been studied in the earlier investigations. In this study, the authors, they have found out that superior hypogastric plexus block is an effective method for the pain control and for improving the quality of life in patients who are suffering from refractory endometriosis. They have also seen that there were no serious adverse effect noticed in any of the patients whom they offered this block, and the positive effects of this treatment, they did not diminish over 24 weeks follow-up of the study. Now, if we talk about endometriosis, it is characterized by the presence of endometrial tissue outside the uterine cavity, and it is identified as one of the very common and a debilitating disease in the females of the reproductive age group. And it has been seen that it is a common cause of infertility in women, and endometriosis is seen in 25 to 50% of the infertile females. If we talk about chronic pelvic pain in females, endometriosis is the main culprit. It has been seen that 45 to 82% of the females suffering from the chronic pelvic pain are suffering from endometriosis. So we see that there is a very high disease burden. A large amount of females suffering from chronic pelvic pain are suffering from endometriosis. And this endometriosis, it results in dysmenorrhea, dyspareunia, chronic pelvic pain, and lot of psychological stress and depression because of the endometriosis related infertility. There are various therapy options available for the pain control or endometriosis, starting from response.
Dr. Namrata, you're there?
Yeah, I think,
The internet issue?
yeah, I told you now, I'm not there. Yeah,
Um,
I'll start again. Okay, is it visible now?
yes, yes. Dr. Namrata, can you hear us?